kick off. Evening, everybody. Welcome to our first in a series of evening discussions around some of the clinical aspects linked specifically to COVID and the management, particularly in critical care environments for people that are not intensivists or not as familiar as they'd like to be with some of the critical care concepts that they may be having to work in the very near future. The topic that we picked for this evening was CPR and resuscitation in the COVID patient. So a couple of things. First off, you might have heard Chris and I chatting. If you have any questions along the way, please, there's a little raise your hand button, which you'll find on your toolbar. If you just click on that and ask, either type in your question straight away or raise your hand and ask the question. Let's rather deal with them as we go. It's a little bit easier than trying to remember them. We'll also have a question session at the end if it's sort of a more global question around this topic. I would just like to mention, though, that we're talking specifically about COVID patients. So a lot of these resuscitation concepts are specific to COVID. They won't hold true to any other setting or situation. And once we go back to normal, a lot of these things will fall away. So it's very specific to COVID. I've got my main reference for kind of what we're going to chat about this evening is a Resuscitation Council of Southern Africa did put out some COVID guidelines. So for example, there's an advanced cardiac arrest algorithm for the COVID-19 pandemic. And a lot of my references will come from that. The European Resuscitation Council, the HA, they've all put out varying guidelines. And what is interesting is that most of them say that it needs to be localized and contextualized, even the Resus Council one. So, and it may even change from day to day, that the way that you approach cardiac arrest may change from week to week, depending on the capabilities of the facility. So, as an example, the British Resuscitation Council put out some guidelines on withholding CPR. But we saw certain hospitals in the UK issuing blanket do not resuscitates to certain age groups for a limited time. So because they had very limited resources at a moment in time, if you were over a certain age, you got a blanket do not resuscitate. So we may see more specific guidance come out in the future, but we're going to talk about general approach to cardiac arrest that we can probably apply from tomorrow. We're going to start off with the kind of preparation phase. And the first one is that we should be doing our utmost to predict the patient. We've always had new systems in place. And the majority of COVID patients that are going to go into cardiac arrest, the arrest is going to be predictable. We're going to see it coming. We're going to see the worsening hypoxia. We're going to know that the patient is going to go into cardiac arrest. So gold standard in cardiac arrest in the COVID setting is predict it and prevent it, or predict it and expect it. That being said, our life-threatening COVID patients, when they reach the cardiac arrest phase, they are severely hypoxic. They're probably in some form of organ failure. And when they're reaching those stages, a lot of those patients, before they even arrest, we potentially should be having the do not resuscitate discussion with their family. In that resuscitating a COVID patient when they go into cardiac arrest, having gone down that whole process, is almost certainly futile. And we need to predict this. We need to know that if we're dealing with a COVID ICU, with multiple ventilated patients, with patients whose worsening stats, despite all the best efforts in terms of ventilation strategies and recruitment strategies, that if they arrest, the chances of them recovering are really, really small. The other issues in terms of preparation will be around PPE, and that nobody goes near these patients without the correct PPE, even though they're now in cardiac arrest. So it's very, very tempting to go, well, my patient's in cardiac arrest, I have to go and help the patient. It's one of the really difficult things to go stop and first make sure that the PPE is right. It's a discipline thing, but it is really important. And the other thing that's really important is to limit the numbers of people that go in and work on a COVID cardiac arrest. We are spoilt in that in a lot of our hospital settings, we would have had 5, 6, 7, maybe 8 people go into a cardiac arrest. That is too many. We want to limit the exposure of staff to these patients, to these situations. So we're needing to be deliberately doing COVID cardiac arrests with 3 staff. And everybody else, even though they feel like they desperately want to help, they do not expose themselves to the situation. There's some talk in some settings for pre-arrest readiness teams. In other words, teams of people that are pre-donned, and maybe if we're working in those COVID ICUs, everybody will be correctly attired anyway. That makes it easier. It means that the patients are able to get interventions a little bit sooner. But there needs to be a fairly solid rule that if the PPE is not correct, the resuscitation does not start. We need to be quite hardcore in making those decisions. And just as hardcore in making sure that we've predicted the right patients. That, and we can use the, the obvious example, the 107-year-old who's been ventilated, who's been proned, who's been all the other interventions possible, that they're hypoxic to the extent that they then go into arrest with multi-organ failure. Starting the resuscitation is probably not even appropriate. So the Resus Council helped out with a little bit of verbiage around this. And I'm going to talk about the out-of-hospital cardiac arrest one first, because that was simpler. And that is that in COVID patients, they recommend against starting conventional CPR in an unwitnessed arrest. That means either when EMS gets to the patient, or when a patient arrests outside of hospital and is taken to a hospital, when it was an unwitnessed arrest in a confirmed COVID patient, do not start CPR. The physiological road that patient had to go through to get to a cardiac arrest means that they've been severely hypoxic for a long time. It will almost certainly be futile. Do not start that cardiac arrest or that resuscitation. In hospital cardiac arrests, there it is. I'm going to read it as written. As a result of the disease process and in general, multi-organ failure resulting in the patient requiring CPR, the reversibility of the disease is unlikely to occur with standard CPR intervention, and then CPR has not shown to be beneficial. The bottom line is there a readily identified cause that is easily reversible? If it's identified and not reversible, CPR is futile, and if it's futile, it should not be done. If anybody reads literature by McCoy Mason from Durban, he very clearly says that futile interventions are unethical and should not be performed. So if it's not readily identifiable and readily reversible, it is futile and should not be performed. So in a normal situation, we shouldn't be doing a futile cardiac arrest. And because of the additional risk that we bring to the staff, in this particular situation, we should definitely not be attempting futile cardiac arrests. There is no benefit. All we do is introduce risk to the staff. If it is a simple rectifiable cause, so for example, the ET tube became dislodged, the patient became hypoxic and went into cardiac arrest, that is easy because that is a rectifiable problem. We can re-establish the airway, re-oxygenate the patient, and attempt to establish a pulse. If the patient goes into a sudden shockable cardiac arrest, that is a easily rectifiable cause. We can immediately shock them, and we'll talk about the phases of cardiac arrest in a moment. But it needs to be readily identified and easily reversible. We're not going to resuscitate for 30 minutes while we try and get a gas to try and find the hyperkalemia that we think might be there. That doesn't fall as readily identifiable and reversible. It needs to be a rapid thing, and we'll talk about timelines in a bit. But these are fairly nice, clean guidelines for the region of Southern Africa that we've been provided with. Did I see a hand raised? No. These are photos out of some of the studies around just chest compressions as an aerosolizing procedure. It's well established that chest compressions alone are aerosolizing. So even chest compression should not be initiated if the staff are not wearing the correct PPE. In the lay public setting, somebody's drawing on the screen, it's quite exciting. In the lay public setting, there's a suggestion that you can put either a surgical mask or a 3-layered cloth over the patient's face while you do chest compressions only. I think the suggestion should be no chest compressions and no airway maneuvers, including BVM ventilations, until all of the staff are wearing PPE. And the PPE must include proper respiratory protection of an N95 level, gowns and eye protection, preferably full face protection for this phase. And you can just see that the only one that showed very little aerosolizing was when there was an advanced airway in place with a filter on the advanced airway. All of the others, there was a degree of aerosolizing spread around the patient. Just a couple of modifications. Unlike normal cardiac arrests, where we would say delay the advanced airway, in COVID cardiac arrest, you probably want the airway sooner so that you can take control of the aerosolizing items coming out. Intubation probably being the best, but it does need to be done safely, which means that obviously all the staff are wearing the correct PPE. There's a couple of things you can do to minimize it, and that is things like covering the patient with a plastic sheet and using video laryngoscopy to do the intubation, just to reduce the gaseous nature. Preferably the person who's most likely to place the tube the fastest on the first attempt. That's the person that you want doing the advanced airway. And no ventilations until there is a filter on the tube. If there's going to be bag valve mask ventilations, and we probably should be recommending away from BVM ventilations, the mask needs to be held sealed on the face all the time, not only when ventilating, but the mask needs to be sealed all the time to the face, and there needs to be a filter between the mask and the bag valve resuscitator. It is acceptable as a third option to use a supraglottic airway, or sorry, as a second option to use a supraglottic airway, as long as it gets a good seal. If after a couple of ventilations you're noticing that there's a lot of spray going on around the supraglottic airway, it may be better to remove it and to attempt a different technique. Intubation is going to be our preferred technique, but as I say, it needs to be done quickly by the person who's going to do it the fastest on the first attempt. And you can then, even once the advanced airway is in, if there's a degree of leak, use a mask or even just a sheet to cover the patient's face to reduce whatever aerosolization is occurring. It's probably good to mention that the bigger the tube, obviously the better the flow of air, but it may reduce the chance of first pass success. So you're going to sort of play up the two against each other. What's the biggest tube that I know I can get in? Not the biggest tube that I think I want to have a bash at getting in. There's a couple of modifications in terms of sequencing. One of them is around the patient that's in a witness shockable rhythm. And it may be that if we're waiting for people to don the correct PPE, the technique that can be done in the meantime is the defibrillation, preferably with pads. There's quite a bit of international literature that's saying you can go ahead and shock them with no chest compressions and no ventilations going on, but shock it in an attempt to resolve the shockable rhythm. And they say you can try that up to 3 times. While you're waiting for the team to don their correct PPE. We've already mentioned that you can consider delaying ventilations or covering the mouth during the process.
Sorry, David, there's a question on the sidebar.
Sure.
What do you do if it is a PUI patient, no result yet, patient arrest? Do you have to first don full PPE?
So we're in a situation now where the volume of critically ill patients around us that are turning out to be positive is such that I would treat every PUI as a positive. And I would apply these rules to the PUIs, bearing in mind that if it's a PUI gunshot, obviously you're going to reverse specific causes around the gunshot. But if it's a PI and is a respiratory distress, chances are so good that it is a COVID positive patient that we should be dealing with them in the same way. I would not be doing any form of resuscitation on a PUI patient not dressed in the full required PPE. I think we're at a point already in the South African setting where it's just not safe to do any aerosolizing procedure in a PUI without correct PPE. Our screening tools are not accurate enough to do it. I probably would suggest that an aerosolizing procedure on a patient that's even had a negative test should be done wearing full PPE, just based on incidence of the patients around us. Just a matter of interest, when we're talking about success rates and that of cardiac arrest, the very early ones, there was one out of Wuhan, where they, in one facility, studied 136 cardiac arrests. They had one survivor. This is in-hospital cardiac arrest, where we would expect survival rates approaching 35–40%, especially for hypoxic cardiac arrests. They had 1 out of 136 successful resuscitation. That's kind of speaking to the futility of doing CPR in a COVID patient. So a couple of things just to talk about termination. They talk about different phases of resuscitation, the electric phase, and then the metabolic phase. And we probably should only be doing our resuscitations into the electric phase. And the electric phase only lasts about 6 minutes, 6 to 10 minutes. It's the phase for as long as the patient is shockable. Now, in a lot of the literature, it's describing that probably 80–85% of patients are not shockable anyway if they're a COVID cardiac arrest, because they're a hypoxic arrest and they're usually going into PEA, which means that they're not really even having an electric phase of their resuscitation. If they're shockable, continue the resuscitation for as long as they're shockable, and you believe you have a reversible cause, or you do have a reversible cause if it's shockable. They have a VF, you can shock it. Hunt aggressively for reversible causes. And remember, we're looking for the reversible ones, so the easily reversible ones. So you were looking for potentially the patient's been ventilated with high pressures and now he's developed himself tension pneumothorax. That's a readily reversible cause that can be quickly fixed and may resolve the hypoxia to an extent to return a pulse. We know the multi-organ failure is not readily reversible. If you haven't brushed up on your H's and T's lately, maybe it's time to go and read up on what your H's and T's are. It's probably also the time that if you have some skill with an ultrasound, that you do some reading on H's and T's in relation to ultrasound. So how do you quickly find a pneumothorax with an ultrasound? How do you quickly get a view of the heart to see what the cardiac activity is with an ultrasound? Can you quickly have a look at an IVC maybe to see about potential fluid dynamics? It's not the best thing, but it may be the only thing you have in the situation. So a lot of people have developed ultrasound skills in other spheres. Now's the time to kind of just hone it into maybe look at some of your cardiac arrest uses of an ultrasound. I said earlier, if you're going to have to wait for a blood gas for 45 minutes to get a blood gas result, that is not soon enough. Don't waste your time waiting 45 minutes for a blood gas result. If you can get it within 2–3 minutes, or you've got a recent one, that may be a gas that you can consult. And you're only really looking for things like a hypokalemia, which are quickly reversible. None of the others are going to be readily reversible. Fairly important to note that because most of these arrests are going to be due to hypoxia, drugs are of no use. So, and in fact, if it's a hypoxic arrest, things like adrenaline will probably make the situation worse. All it does is up the oxygen demand from a myocardial tissue perspective. So, doing funny things like spraying adrenaline down ET tubes or giving large doses of adrenaline IV or IM boluses of adrenaline, That's not the focus. The focus is on what is reversible. If it's not reversible, just going through the motions of particularly drugs that are of no benefit or may be harmful should be weighed up. Most of these patients will not be shockable, so things like amiodarone and lignocaine are of no benefit. Things like Sodibic, unless you have a definite reason to give Sodibic, that you know that the patient is massively metabolically acidotic and their bicarb is already low, maybe Sodibic. But Sodibic as a routine drug should not be given. Lignocaine, amiodarone, all of those medications should not be given routinely in any of these cardiac arrests. We shouldn't be prolonging cardiac arrests so that we can get the drugs in, because there's no benefit in that. If the patient is in asystole especially, we should consider early termination. So the Resus Council paper talks about 6 minutes of resuscitation. The Americans have spoken about 10 minutes, and that's not your minimum resuscitation time. That's considered your maximum resuscitation time. So if you start in asystole or a really slow PEA, and they don't do anything, they don't respond in any way, 10 minutes, if you're American, 6 minutes, if you're reading the South African stuff, should be your maximum resuscitation time. We're limiting the dangerous exposure to our staff in a situation where it's probably not going to make any difference to the patient. You may even, some staff will start their resuscitation because they don't know the history of the patient, or they don't know what's going on with the patient. We may only resuscitate until somebody arrives that does know the patient. And they can then say, well, this patient is also has a terminal disease, or this patient has signed a DNR. It's perfectly acceptable to then stop. There is no rules, regulations, or requirements to continue resuscitation for any minimum amount of time. As soon as, probably the easiest way to kind of bottle it is to say that as soon as futility is established, that is the time to stop the resuscitation. Gone are the days, in fact, before COVID, gone are the days, we would resuscitate, or we should be resuscitating for 45 minutes or an hour and a half just because we didn't want to stop. The resuscitations you're going to win are the ones that are going to win within the first 10, maybe 15 minutes. Any longer than that is almost certainly futile, and definitely futile in the COVID setting. What about pediatrics? Well, the thing that makes us resuscitate for longer in the pediatric setting is the fact that they are children. From a clinical perspective, the child that has deteriorated to the point of hypoxia into cardiac arrest is just as much as in trouble as the adult, and is just as unlikely to respond to CPR as the adult does. We should be preventing the cardiac arrest in the pediatric patient. So getting on top of the hypoxia before they even get to cardiac arrest, rather than trying to cope with it after. Trying to cope with it after is going to be a futile exercise. It sounds very doom and gloom, and I'm sorry about that, but unfortunately this is the reality of cardiac arrest in the COVID setting. I've just put this up. Yeah.
Just a question on the chat. When are they shockable?
So there's only 2 times that we would shock any cardiac arrest patient, and that is a ventricular fibrillation and a ventricular tachycardia that has no pulse. Those are the only rhythms or patients with rhythms that we would consider defibrillation. There is no other rhythm that benefits from a shock, as much as the movies want to encourage us otherwise on a regular basis. PEA does not get shocked. Asystole does not get shocked. Only a ventricular fibrillation or a VTAC with a pulse. If you're not comfortable with rhythms, and a lot of people are not reading ECGs on a daily basis, then use an AED. That's what AEDs are there for. If you're not comfortable with identifying the rhythm, there is no embarrassment in using an AED, because the AED will identify the rhythms for you. And most of the modern AEDs that we have are quick. Most modern defibrillators have the ability that you can select an AED function. So even if you're in an ICU where there's no AED available, the defibrillator can be switched to an AED function and let it make the decision for you if you're not completely comfortable with identifying what is a VF and what is a VT, ventricular tachycardia. Maybe just quickly on that topic while we're talking about it, if you're comfortable with identifying the rhythm, but maybe it's a machine you don't know and you don't know what energy setting to use, turn it to its highest setting and shock them on that. The objective is to terminate the shockable rhythm. So, you know, don't hunt around for a manual trying to work out what the energy setting should be. Just go to the maximum what the machine will give you and use that. If you're using the AD function, it will decide for you what energy to use. Cool. Just quickly, so this algorithm is one of the few that are available. If you're looking for these algorithms, they're on resus.co.za. They've got a basic life support one, they've got one for the public, and they've got the advanced life support one. And really, the one thing maybe that they haven't spoken about at the beginning is this a patient for resuscitation? They've sort of mentioned, is there DNR in place? And I think that's something that we're going to need to be getting a little bit more aggressive with in the near future, and that is identifying the patients that are not for resuscitation before they rest. If we decide that it is a patient for resuscitation for whatever reason, we believe that there's a readily rectifiable cause, we have to climb in and do the resuscitation properly. PPE first. Limit the number of people that are going to be in the room. The algorithm talks about crowd control. We don't have to have 8 people in the room. And in the room is important because it's aerosolizing, and aerosols can travel a fair distance. So if you're not actively involved, you're not part of the 3, maybe 4 people that are doing the cardiac arrest, don't be in the room. There's no reason to be there. Get whatever help you need and start your resuscitation. I would suggest that in most in-hospital settings, there is the right equipment, that the first thing we can do is put a BVM mask with filter over the patient's face, and a second person can then start chest compressions, because immediately we're then taking control of any aerosolizing items flying around the room. If that's not available and only one person's there on their own in PPE, they may consider putting something over their face, putting something over the patient's face while they start just chest compressions. As soon as possible, get to analyzing a rhythm to see what the ECG says, or attaching the AD. Follow that to decide if it's shockable or not shockable. On the right-hand side, it does talk about some of the airway management things. I know it's really little, but go and have a look at the algorithms. My suggestion is that these algorithms should be up in most units at the moment, just to be there as a bit of security for the staff. Sorry. Lost my train of thought while I dealt with something quickly. It must be deliberate and it must be quick, any action that gets taken. So airway management, if it's going to be done, must be done by the person, as we said, who can do it the quickest and the best. Make sure that you don't start ventilating until you've got filters on at least your BVM, filters between the ET tube and the vent circuit. In a lot of settings, we're having to reuse ventilator circuits. So make sure that there's a filter in place. Ideally, we don't like using ventilators for most cardiac arrests because of PEEP control. But if we're doing limited contact cardiac arrests or limited people cardiac arrests, what we may want to do is use a ventilator for those. If you're going to use a ventilator for a cardiac arrest, just remember that the PEEP must be turned to 0, and you're preferably using it in a volume control mode, where you can just set a volume and a rate. PEEP should be on 0 for any cardiac arrest. We know we're dealing with lung pathology, and tomorrow night we're going to talk about PEEP and ventilation, but in cardiac arrest, the output is so bad that the PEEP must go down to 0. Otherwise, the output is null and void. And then there's just some of the normal cardiac arrest things. Don't avoid excess ventilation. And we talk about ventilation at about one breath every 6 seconds in most of these patients. If there's capnography available, expect the capnography to be very deranged in a COVID patient. It may be useful during the cardiac arrest to tell you about how good your cardiac output is, but as soon as you have a pulse back, please don't target end-tidal CO2 in a COVID patient. I know that they've left adrenaline on this algorithm, and I actually discussed it with a couple of them afterwards. It should be really far down the list of things to do in a COVID cardiac arrest. As we said, they're almost always going to be hypoxic arrests. Adrenaline is not a hypoxic arrest's friend. What we're probably wanting to do, and it's bottom right-hand corner, is the contributory causes. We want to identify, is there a reason that the patient acutely went into arrest other than hypoxia? We'd hate to miss the tension pneumothorax that is a rectifiable cause. Hopefully there's not trauma going on in most of these patients. If they're arriving and they're trauma, it's a completely different resuscitation. Hydrogen ion abnormalities and potassium shifts, we should have been watching that for the duration of the patient leading up to it. So if they're in an intensive care kind of environment, we would have been noticing the potassium change over time, hopefully, or noticing the building acidosis. We need to fix those issues before they go into cardiac arrest. When they reach the point of arrest, the organ failure that is likely to happen, coupled with a really bad acidosis, is such that they're unlikely to have a long-term prognosis. And that resuscitation should again be a short one. In COVID patients, there is no reason for a prolonged resuscitation. There are very few settings in the world that are doing interesting extra bits like ECMO, CPR on COVID patients, because in general, the results have not been shown to be amazing outside of a select few very specific patients. So if you're in a facility that doesn't have the ability to do ECMO, or in a facility that will do ECMO but only later, if it's not lined up and ready and waiting for the patient, it's probably going to be too late and would probably be of no benefit to the patient anyway. Okay, those are the slides that I'd prepared just to get us through the highlights of COVID cardiac arrest. I want to now just see if there's any questions or any points of discussion around this group of patients in cardiac arrest.
Thank you, David. Just as a reminder for everybody on the session, please just raise your hand and then I'll unmute you so you can verbalize your question.
I think while I'm waiting for anybody, if anybody's going to ask a question, I probably just want to reiterate what I think is the most important part of this whole thing, and that is the concept of futile cardiac arrests being unethical. The emotion around this will always be high. We know that in the current climate, all of our healthcare professionals are stretched and stressed and struggling to cope with what's going on around them. And making some of these decisions is going to be really tough, because unfortunately, a lot of these patients are arresting after they've been with us for a while. We need to take the step back and acknowledge that if they reach the point of cardiac arrest after prolonged hypoxia, prolonged lung disease, they are not going to survive. And doing resuscitation just because maybe it makes us feel better or because the family demands it is a futile procedure and it should not be done. It's a hard decision, but unfortunately in the coming weeks, it's going to be a decision that a lot of us are going to have to step up and take on a rate or number that is going to make us uncomfortable. I think we need to acknowledge that up front, that it's going to be unpleasant and that it's what we need to do to look after the better part of the community and to look after our fellow healthcare providers. I've made everybody very somber, and I apologize.
David, there are some questions on the sidebar.
Yeah.
The first I'm seeing is from Kieran. In a ROS patient, can we place patient prone with tube in place? Beneficial or not? So just for clarity, it might just be worthwhile just to expand abbreviations that everybody in the call does know. And ROS is return in your circulation.
Cool. So the question is around the patient who's got a pulse back following cardiac arrest. So return of spontaneous circulation, called ROSC. So we now have this patient who usually will be very on edge. Turning a patient prone is certainly one of the techniques that's been identified as a very good technique for assisting with oxygenation and recruiting alveoli. It's got to be balanced against stability of the patient. I'm not sure if it's a technique that should be done immediately in the post-resuscitation phase. I think it's something that we're going to hold off on probably for 20 to 30 minutes while we're waiting for the cardiac condition of the patient to just stabilize a little bit, and that then can be introduced as a recruitment or an oxygenation technique. It may be something that we want to introduce as a prevention of a repeat arrest because the patient is that hypoxic, but we know that moving patients around, particularly when they're very unstable from a cardiac perspective, it introduces its own risk. So yeah, it's a difficult decision. I would say preferably after a pause, just for that myocardium to settle a little bit. Next, Chris.
The next one I see here is from Vanessa. Why to not use adrenaline with hypoxia?
Okay, so what adrenaline does to cardiac tissue is it will speed up its activity, which is the theory behind why we do use it in cardiac arrest, is because we want the heart to be doing whatever it does faster. The trouble is, the counter to that is it speeds up its activity, but at the same time makes its oxygen demand greater. So what you end up with is this hyperexcited cardiac tissue that is demanding more oxygen. And if this is already in a hypoxic state, all that you end up doing is making that cardiac tissue sicker faster. So in the presence of hypoxia, in fact, we know things like atropine are certainly contraindicated completely. Adrenaline is almost relatively contraindicated in the presence of hypoxia because it makes the metabolic state of a myocardial cell worse, unless you've resolved the hypoxia. It's not going to work. The other problem with it is that if you're severely hypoxic, you're probably going to be significantly acidotic, and adrenaline in a very acidic environment is also going to have zero effect. So what we sometimes see is people are so wrapped up in wanting to give the drugs that they forget about the basics. So they end up doing things like hunting for strange intravenous access, forgetting about high quality CPR to give a drug that's probably not going to make any difference anyway. Chris?
Thanks, David. No further questions I'm seeing on the sidebar. I'm going to do a slightly different approach. I'm going to just unmute all, or allow everybody to unmute themselves.
Yeah. I started again. So
okay, I take that back. That seemed to open a can of worms. So if anybody would like to unmute, please just raise your hand and I'll unmute you. Sorry, Mandy, your line's really soft.
Is this better?
Slightly.
Okay. I hope this is better. I'm in a large call center, so it's difficult to actually unmute and speak loudly. I just want to ask, just mention something that is.
Sorry, Mandy, your line's quite bad. Let me call you on your cell phone quickly, and then I'll just put you on.
Can you hear now?
It keeps going soft. So I'll give you a ring on your cell quick.
Okay.
call in now.
Hi, Chris.
Okay, Mandy, just mute yourself on Zoom.
Okay, can you hear me, Chris?
Yeah, I can. Go for it.
So just to make when we look at our CPR that's been done in our facilities at this stage, we've had 3 episodes of CPR done on PUI patients, 1 and 2 COVID positive patients. And in each incident where staff were not wearing the appropriate PPE, they have been converted and they have been become. So David cannot stress more than he has already stressed how important it is that there are packs in the hospital available if you are going to do CPR, and that you practice safety first before you move on to CPR. Thanks.
Perfect. Thank you, Mandy. I trust everyone is able to hear that. Are there any further questions? There's a few messages of thanks, David. I'm not sure if you've seen them, but just to express everybody's thank you for the lecture and for the clear information and message.
Chris, I just wanted to come in for 1 second, if I may.
Sure, sure. Sorry, Richard, you've gone back on mute. Are you still there?
Yeah, I just wanted to say something I posted on the sidebar to David's comments earlier regarding PUIs. We're now seeing 2/3 of our cases that we've admitted into hospital converting to becoming positive. So exactly what David was saying with regards being very careful around PUIs is absolutely valid. At the start of the pandemic, it was only 1 in 10 PUIs that converted to positivity. We're now seeing, and it's rising every day, it rose from last week at about 51, 52%, now up to 65%. So one has to treat these PUIs with as much caution as one would a COVID positive patient.
Perfect. Thank you, Richard. There don't seem to be any other questions coming up on the sidebar. I'll do one last call for further questions or comments. Okay, thank you, everybody. David and Mandy, I'm not sure there are any further closing comments from your side.
Maybe just to say to everybody, thanks for joining. Thanks for taking out the time. We're going through some tough times in the near future. We've got some pretty useful and interesting topics lined up for the coming evenings, and would encourage everybody to join those. It's topics that people may be going into situations or helping in situations where they either have no experience or the experience was a little bit old and rusty, and we're going to have the opportunity just to go through those concepts and just try and get everybody comfortable dealing with them. We'll package it as quickly as and in as useful fashion as possible.
Thanks, David. And just a further comment to add, we're going to try and change the structure of these sessions slightly. So there will be a message going out, which I'll post now on this group, which will include registration details. If you can please use the link to register for this session. Through the registration, you will then do your CPD certificates as well. And you can also forward that message to others that might want to register. We will also we have these sessions recorded, so we will try our best to make those recordings available either through our e-learning platform or through some other social media online platform, but we'll communicate that accordingly.
Well, I just spotted one question there about the algorithms. The easiest way to get hold of the algorithms is to go onto the website, www.resus.co.za. All of the algorithms are there. They're free to download. There's no copyright on them. You're allowed to print them, copy them, whatever you need to do with them, and make them available to your staff. So resus.co.za.
Perfect. Thank you, David. And thank you, everybody. I don't see any further questions or comments. So perhaps we can close the session for tonight.
Perfect. Thank you, everybody.
Okay, thank you all. Have a good evening, and we'll see you tomorrow night.